What do you do if you're sick with symptoms that worry you, but you don't have a family doctor or there's no walk-in clinic to turn to? People need health care from a doctor or nurse practitioner, but some turn to this. The local emergency department. Each year there are over 15 million visits to ERs across Canada. But new data is showing that about 15% of these, 1 in 7, are for health conditions that could potentially have been treated in primary care. We're going to talk about how to interpret this new data with ER physician Howard Ovens.
The most important thing is what we don't do. We don't misinterpret the data and blame patients for coming to the emergency department, causing emergency department overcrowding. If you think you have an emergency, come to the emergency department. We want to see you.
We'll also talk to a patient who says she had no choice but to go to Emerge. Her doctor wasn't around, and Shelley Petit says she actually felt ashamed to take up a spot in a crowded New Brunswick emergency unit.
I was in so much pain. I knew there was something severely wrong, but at the same time, I felt guilty being there. That what if I took the place of one of these babies? They're in so much pain. Or, a senior.
Welcome to the Canadian Health Information Podcast. We call it the CHIP for short. I'm Avis Favreau, the host of this conversation. A note, the opinions expressed here don't necessarily reflect those of the Canadian Institute for Health Information, but it is an open discussion, and this episode is about how the national crisis in primary care is showing up in emergency rooms across the country. We now welcome Dr. Howard Ovens, a longtime ER physician in Toronto. Thanks for coming on the show to explain the data, Dr. Ovens.
Pleasure to be with you, Avis.
Okay, so the key question or the key point in the data is that CIHI surveyed over 1.2 million ER visits in 6 provinces. And when they look at the analysis according to why they went to ER, about 1 in 7 people who were there potentially could have been seen and helped by a family physician or nurse practitioner. When you saw the data, were you surprised by that, 1 in 7?
So there are 2 groups of people buried in that statistic. The first group thought they had an emergency. They were concerned, anxious, and presented to an emergency department. And luckily, turned out that their final diagnosis was one that was not particularly serious. They were discharged, and the diagnosis on their chart is one that you could see in a family doctor's office regularly. To me, those people belong in the emergency department. They thought they had an emergency. We're all glad that it wasn't in the end, but it took some thinking and assessment by an emergency physician to make that determination. There are other people who didn't really want to come to the emergency department. They just couldn't find an alternative. They don't have a family doctor, and those people in frustration come to the emergency department. And ideally, in a well-designed healthcare system, those people could have accessed their alternatives.
Let me share part of our interview with one woman, Shelley Petit from Fredericton. She actually has a family doctor, but he wasn't available. Have a listen.
I was in so much pain. I felt like I couldn't stand, but I couldn't sit or lie down. It was just, it all consuming. And to the point, it was really, really scaring me. So I thought, okay, there's something really, really wrong. I need to go get checked.
You're one of the lucky Canadians who does have a family doctor.
Yep.
Where was your physician? Could you go see him or her?
He was working at another hospital at the time because in New Brunswick, family doctors have to do a couple weeks within the ER at all times. And so called the office. No, he's working at the other hospital, but it was not the acute care hospital, which is where I had to go. So I couldn't even potentially see my family doctor. And we're so short on doctors.
And so then you turned to virtual care. I mean, you were doing your best to avoid the ER. I give you points for this.
Yeah, I called virtual care. I called the system, did the online, and they told me, no, you have to go in. We can't help you with this.
Why?
because they thought I would need labs done. I might need an x-ray done. So I had to go into the hospital. I was trying with everything to avoid it, but to no luck.
So, Dr. Evans, do you see these sorts of cases? They have no doctor, or like Shelley, they just don't have another option?
Every single shift.
Really? Tell me why they're there. Why are they coming to emerge?
Well, the total range of healthcare concerns, from things like my family doctor retired and I don't have anyone to prescribe my blood pressure medication for me, to I've got a fever, sore throat, I'm not feeling well, I've got abdominal pain, and the full gamut of reasons that people come to emergency departments.
How do you feel when you hear that?
First of all, it's challenging and at times almost sad for patients who really have some problems that require continuity of care, that they don't have that service when they're entitled to it. They've paid taxes for it. And of course, it's frustrating because it adds a further degree of complexity to our work, which is already by its very nature challenging and complex. And now you've got another layer, which is I've taken care of today's problem, but what are they going to do next?
Do you feel that group of patients is growing, or the severity of their problems that they're bringing to the OR is increasing?
Both, because of the crisis in access to primary care, the duration of time since people who previously had a family doctor have gone without an annual checkup or screening exams that are recommended by our best evidence. They haven't had these things done in some time, so other problems have developed or progressed.
So you're seeing, for example, people show up with advanced diabetes?
All kinds of problems that have been left to fester: diabetes, hypertension, in some cases, early symptoms that we've done some research here at Sinai, one of my colleagues, on unfortunately how frequently we diagnose cancer in the emergency department.
I've heard that. It must be so hard because in a lot of cases, these can be detected early or prevented, like colon cancer. How do you feel when you see a case like that? What does that do to the morale of your,
Well, there's always complexity in healthcare, but we are seeing, unfortunately, a bit of an increase in prevalence of colon cancer in very young people, 20s and 30s. And I have made that diagnosis myself a few times. Very memorable, very sad, because usually when we're making the diagnosis, it's not an early diagnosis. And of course, this can be very devastating.
So in the context of this report, it's really a sign that the primary care system is not working the way it should be. Can we put it that way? How would you phrase it?
This data is not directly measuring access to primary care. It's a proxy for that because we don't have CIHI. When I say we, the healthcare system, CIHI doesn't have data on primary care access, primary care visits. We don't have a number that tells you, even of those people who have family doctors, how many can get an appointment within 24 or 48 hours when they need it. We don't have that data. So we try to squeeze some of information implied out of the emergency department data. So it's a proxy for what we're talking about.
And so what does the data tell you?
There is a signal here which can be most appropriately measured against itself over time and between jurisdictions to give us information about trends across the country, by community, and over time about access to primary care. When we take that data and combine it with what we both know from healthcare system data more broadly, as well as our personal experience working in emergency departments, we know that there is a crisis in access to primary care.
So here's a bit more of our interview with Shelley. Not only was she desperately trying to avoid going to an ER, she said she actually felt terrible about sitting in this packed waiting room despite being in severe pain?
Oh, war zone. I honest to God, this is what I think it looks like in the hospitals in Palestine and Israel right now. It's just so many bodies everywhere begging for help, begging for help.
Really? That
Yeah, yeah. Help me. They're in pain. People are crying. It's the worst is when the children are there crying, and it's heartbreaking. And we've had people that are dying in waiting rooms here in New Brunswick, and this should not be happening. I don't understand it.
did you feel guilty?
Yes, I knew I was in excruciating pain. I knew there was something severely wrong, but at the same time, I felt guilty being there. That what if I took the place of one of these babies? They're in so much pain. Or, a senior, because I think of my mom who's been going through stroke issues. And how can you feel okay being there when you know so many other people might need the same bed you do?
Guilty about going to the ER. That's pretty powerful. Dr. Evans, do you hear patients say that?
Yes.
What does that tell you, or what concerns you about stories like that?
I don't want any patient to feel guilty when they are seeking help for a problem that they are worried about or suffering with. So I'm very sorry that the deficiencies in our healthcare system made anyone feel guilty for seeking help. She's also not the main problem causing ED crowding and long waits. That's much more related to seriously ill people who need to be in the hospital but are waiting for a bed in the emergency department for many hours and in many cases, many days, and using up limited resources of nursing time and bed space, stretcher space. And so our efficiency in seeing new patients is severely compromised. And so she shouldn't feel guilty. We're very grateful if people like that are patient and polite to the staff. People get very frustrated and angry with us at times, but she should not feel guilty.
Other patients have told us that they try to avoid going to the ER by using virtual care, the virtual care services. But several of them told us that they are often told to go to Emerge because the doctor on the other side of the Zoom call doesn't have the skill. So is virtual care helping or hindering care?
So I'll have to choose my words carefully. We do feel, me and my colleagues who work in emergency departments, that there are areas in the healthcare system that have been designed for the advantage of providers rather than patients, and where they are mostly focused on doing quick assessments of relatively simple problems, and where if you're going to take up more time or resources or expose them to more liability, they will refer you pretty quickly to an emergency department, whether you think you have an emergency or not.
You're referring to walk-in clinics and virtual care in some cases?
Yes. So to me, virtual care, it is fantastic that a patient who didn't really want to see their doctor in person, maybe they, again, need a prescription renewal, maybe they want to discuss the results of a test they just had, or follow up on a problem with a physician they know who knows about that problem. And saving them time and parking and travel expense and treating them virtually is fantastic. But as the initial assessment of an undifferentiated problem, it's challenging and it's very unhelpful if the service that's provided is not connected to the rest of the healthcare system so that proper continuity of care can be observed, warm handover referrals can be made, records can be kept which are accessible to other members of the healthcare team. And we do have a lot of providers, both individual physicians, groups, and corporations who have designed a system that is profitable but does not, does not meet holistically the needs of these patients and relies a lot on emergency departments to be their safety net.
Interesting. That's a question that Shelley, the patient in New Brunswick, actually asks herself. Did the virtual service help her avoid the ER? No, it didn't, she says. Here's part of her interview.
I think it was a cover your butt situation. We don't know quite what's going on. We can't really tell. You probably need labs or an x-ray. So you go because we don't want to be responsible if we tell you, well, no, just take some extra Tylenol and try to deal with it. In case it was something more severe and you have a worse response down the line.
So you went reluctantly.
Yes. I avoid the hospital with everything I can.
So, Dr. Evans, what do we do with the data that CIHI has collected here?
So the most important thing to me and my colleagues is what we don't do. We don't misinterpret the data and blame patients for coming to the emergency department or blame people without family doctors or without access to them for causing ED overcrowding. What we do is use it as one of a number of measures over time to tell us if we are finally starting to address the access to primary care crisis. Are we creating more capacity for comprehensive primary care, more ability of groups of family doctors to see people in a timely way for urgent, unscheduled types of problems?
So you would want to see this 1 in 7 decrease over time.
Absolutely.
That's a marker you would like to see. So I guess to sum up then, people may be confused, and I have a sense that a lot of people don't even go to emergency. Does that worry you when data comes out and it's misinterpreted?
Yes. So we are always seeing, and we're always afraid of, very responsible people who read about long wait times in emergency departments or hear people in leadership positions talk about inappropriate use of the emergency department, and they decide that they better tough it out at home, and they're actually losing precious time with a time-sensitive issue. And we see them when their appendix is already burst or their stroke or heart attack can no longer be reversed, et cetera.
So the data, when it's not appropriately framed, can scare people away and cost lives.
Absolutely.
Interestingly, the patient, Shelley, feels exactly the same way. And she had this message.
It's your body. Listen to your body. We know our bodies. Sometimes you get an ache or pain, like, oh, but it's going to go away in 5 minutes and it's going to be bad. But, we've been through all this in our bodies. But when like, this is not normal, this is not a natural pain, this is bad and it's staying and getting worse, you got to go, just bring a well-charged phone and a book and some snacks.
So to sum up, Dr. Evans, we've got to be careful with the data.
I think this data is more useful to healthcare system leaders than to individuals. Again, this is an important signal among many that can give us a scorecard on how we're doing in rebuilding the primary care system, which is the foundation of our healthcare. My message to individuals and their families who may be experiencing a concern is, if you think you have an emergency, come to the emergency department. We want to see you.
All right. Thank you very much, Dr. Evans. Appreciate it.
My pleasure.
There's much, much more data on this report, including provincial differences in ER visits by patients who could potentially have been taken care of in primary care, but weren't. It's all posted at CIHI.ca. Thank you so much for listening, and please subscribe to The Chip wherever you get your podcasts. I'm Avis Favreau. Talk to you next time.